Hi everyone, welcome back. In this episode, we'll be talking about the second type of IV to oral switch, which is step-down therapy. Recall that the first type of IV to oral switch was sequential therapy, where we're changing a IV antibiotic to its equivalent oral form that has high bioavailability, so high oral absorption. Step-down IV to oral switch refers to changing the IV antimicrobial agent to a different oral agent. In contrast to sequential therapy, the oral agent in this case may have lower oral bioavailability, it may be in a different class, or it may have similar or different spectrum of activities. In this slide here, I've listed out some common IV to oral step-down examples that I see in my practice. The first example here is switching from IV ampicillin to oral amoxicillin. They're two different drugs, but have similar spectrum of activity. The second example I have listed is switching from IV penicillin G sodium to oral penicillin VK. And then we have switching from cefazolin, a first-generation cephalosporin, to another first-generation cephalosporin, but in the oral form, such as cephalexin. And then we have switching from a third-generation cephalosporin, such as ceftriaxone, to a oral second-generation cephalosporin. In this example, the spectrum of activity is a bit narrower with the switch from third to a second generation cephalosporin, so hence it belonging to the step down type. And lastly, I listed here switching from IV piperacillin tazobactam to oral amoxicillin clavulanate. Recall the 7 principles that you should always keep in mind whenever you're reviewing your patients for an IV to oral switch. The first is that there is an infection diagnosed and that the patient continues to need antimicrobial therapy. The second is that the infection is not one that may require prolonged IV therapy. The patient must be clinically stable and improving prior to the switch, and they must be able to tolerate their oral diet or oral medications okay. You want to also ensure that there is nothing that will affect their oral absorption, such as an abnormal gastrointestinal tract, and that there is an oral option available for you to switch to. As with the previous videos, I'll illustrate how to use the 7 principles to conduct an IV to oral step-down switch with a case. So meet Mr. AX. Mr. AX is an 80-year-old male admitted with E. coli bacteremia secondary to a urinary source. He's currently on day 3 of ceftriaxone 1 gram IV every 24. His past medical history is significant for type 2 diabetes, dementia, urinary retention that requires a chronic Foley catheter secondary to his benign prostatic hyperplasia. Mr. AX's concurrent medications include tamsulosin 0.4 mg daily, metformin 1 gram twice a day, and ramipril 5 mg daily. You review Mr. AX's microbiology culture results and find that there is E. coli growing from his blood cultures. It is sensitive to ampicillin, cefazolin, ceftriaxone, and ciprofloxacin. You find that the same isolate of E. coli is growing from his urine as well. His labs show that his white count has decreased to 8 from 20 on admission. His serum creatinine is back now to baseline and is stable at 75 micromoles per liter. His GFR is reported to be 60 mils per minute today. His LFTs are within normal limits. You look through Mr. AX's imaging results to see if there might be a deeper focus of infection, such as an abscess associated with his E. coli bacteremia. You found that there is an ultrasound of the abdomen pelvis done yesterday, which showed no evidence of such and no abdominal pathology. Next, you check how Mr. AX is clinically doing. You see that he was initially febrile on admission, but has been afebrile for the past 2 days. His blood pressure and heart rate has been stable, and that he's sitting at 98% on room air. You also note that he's tolerating his liquid diet with no vomiting or diarrhea noted. Now let's bring everything that you've uncovered on Mr. AX back to our 7 principles. We know that number 1, he has an infection, which is the E. coli bacteremia secondary to a urinary source that would require continuous antimicrobial therapy for 7 days. This infection is not something that would require prolonged IV therapy for, and we know that Mr. AX is clinically and hemodynamically stable. Number 4, we also know that Mr. AX is clinically improving. He's defervesced since he's been admitted and his white count has normalized. He's also tolerating his oral liquid diet as well as his oral medications without any vomiting or diarrhea documented. And there is an oral option available based on the E. coli sensitivity. We have oral amoxicillin and oral cephalexin as potential step-down options. And there's nothing that we could find in his chart suggesting abnormal GI tract that would hinder his ability to absorb oral medications. This slide is just a reminder to everyone that we should be mindful whenever we're reviewing and selecting antimicrobial therapy options. I want to bring your attention to N as in narrow and D for duration, as well as F, find the right dose, and U, understanding the drug. So first of all, narrow. We know that Mr. AX's E. coli is sensitive to quite a few antibiotic, including ampicillin, cefazolin, ceftriaxone, and ciprofloxacin. Now, comparing all of the spectrum, we know that ampicillin is our narrower spectrum. Given that he does not have any contraindications to receiving ampicillin or amoxicillin, which is the oral equivalent, this would be something that we would consider. D stands for duration. We want to use the shortest duration possible to treat the infection effectively. A longer course of therapy does not mean better outcomes. We know that for E. coli bacteremia with source control and no deeper focus of infection, a 7-day course is adequate. We want to make sure that the oral agent that we select will also penetrate to the site of infection. We know that ampicillin or amoxicillin would reach the urinary tract and kidneys as well as the serum in good concentration in order to treat the infection. And we want to make sure the dose that we pick is appropriate for his kidney function as well. After our review, we decided to suggest to the team to change Mr. AX's IV ceftriaxone to oral amoxicillin at a dose of 500 milligrams PO 3 times a day for 7 days total, counting from the day of ceftriaxone start. For good practice, always collaborate with your medical team whenever you're reviewing your patient's antimicrobial therapy for an IV to oral switch. This is to make sure you're not missing anything. Always double check your local institution's guidelines or policies to see if there is any that would help guide your IV to oral switch, and for any institution-specific doses for antimicrobials that are approved by your Drug and Therapeutics Committee Board at your hospital. Lastly, after you make a recommendation to switch your patient from an IV to oral medication, you want to monitor to make sure that they're tolerating the medication okay and that they continue to improve.